Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Michael White, Community Medical Services. What is your job title, and what are the responsibilities of your role?
My job for Community Medical Services is basically an advocacy a position. However, in that advocacy comes projects with hospitals, jails, fire departments, those types of external supports for the community members that are struggling with the opioid crisis just like us. We want our individuals or our patients to be able to connect with those community providers, community connections, and not be stigmatized or discriminated against. So developing those relationships helps our clients have a better experience through their recovery.
How do you find clients, organizations, and systems that are looking for you to act as its advocate?
It can change and it's kind of evolving. So I would say now people reach out and they're trying to get ahead of the curve or an incident happened, but very much back in the day, it was because of tragedy. And so we would hear a story about a mother getting her child taken away just because she was on medication-assisted treatment, and the judge was basically ordering for severance, meaning the child being taken away from mom just because she was on MAT, and she could have been sober for 2 years, but she's utilizing this medication. So the stories like that, or there could have been a death in the jail, and so prompting that jail staff that these things are needless and they don't need to happen. There is a solution to what they're kind of going through and struggling with. And so it's a lot of my projects, unfortunately, are developed on tragedy.
What is a positive outcome you helped create?
So I've seen a lot of children returned home due to a lot of work that our peer supports do and a lot of work that our case managers do by going to child family team practices and those types of things. I've seen jails like Maricopa County Jail, for instance, start handing out naloxone to people being released, along with harm reduction cards on how to keep safe and alive and not get Hep C and other medical issues that might come with opiate use disorder. But just a system change from corrections all around has been something I've been fortunate enough to see in the last 5 years, where they are truly saving lives. They are having people come in on their worst day of life. They get them on a medication, and we have some data through the Matt Padoa grant that demonstrates that people get on MAT, they get released from incarceration, they do really well. They get jobs, they get permanent housing, they do all those social determinants of health. And so overall, it's just been great to see the change.
Are there any specific challenges you face when working with a correctional institute?
There's always challenges. In my world, it's kind of separated in three groups. So you have kind of the third-party healthcare provider, usually if it's a bigger type of jail or system. You have the sheriff, sometimes elected, or you have the governor-appointed director of the DOC facility, but then you have line staff. And so to get those folks all aligned on the same issue sometimes is problematic or hard. But I think after you get a program set up and moving, the benefits that they see, they align very quickly. So, the suicide observation rates of 15-minute intervals go down because not as many people, especially when they're opiate use disorder, they're not on suicide watch. They've started this medication. They're not having bodily functions from withdrawal take place in the cell. They're going home safe to their families. I have a cousin that worked in corrections and got accidentally pricked by a needle. So he couldn't be intimate with his wife for 6 months because they didn't know if he had something or not. And so those stories hold true for me and my family just going home safe. Corrections officers deserve to go home safe too, in all this. And I think it cuts down on a lot of resources that jails spend on the opiate use disorder population.
From your perspective, how have things changed since you started working in the field?
Everything. So yeah, absolutely everything. It was a fight back in 2015. Babies were being taken away from home, from moms. Healthcare providers within the system are judging patients based on, a disease that they have, and holding this carrot of medication, whether they were, if they deserved it or not. Everything. I mean, it's just day and night.
What positives do you see in such grim situations?
Maricopa County Jail, they knew the numbers, so they were having 900 people every month come in with opiate use disorder. 450 of those could be diagnosed with opiate use disorder. So they knew they had this revolving door, and they knew they had this issue. So with those numbers, they decided to make a change, and they got an independently licensed OTP in their system, all 5 jails. To say that they've saved lives would be an understatement. I mean, they've made an impact on Arizona and all. And then with the ability of that, you start leveraging that story and Dr. Clark's story and Rikers Island, who's, one of the originals, and those types of things. And it's just appropriate healthcare. Somebody doesn't have to die for getting a traffic ticket because they're on heroin or alcohol or you name it, right? So withdrawal doesn't work. Detox doesn't work for this population. It's 10 to 12% outcomes. We have something that works 40 to 75% of the time, whatever data you want to look at. And it's just appropriate healthcare. So I don't understand. I'm still on this grim mark, I guess. But the change we're seeing places in Montana, small, Minot, North Dakota, they're doing MAT. North Dakota DOCR is phenomenal. They're doing it up for 36 months, getting 90% of their opiate use disorder population because they're out within 32 months, and they're doing all 3 medications. So I've been able to see a lot change. There's still a lot to go, but then you've seen state and federal organizations like yourselves jump on and be able to help people. You see a lot more information and education taking place at, NatCon and RX Summit and all these other places that used to be like the OTPs used to be the black sheep of the behavioral health industry. And so it's been different to see agencies just return our phone calls, because that wasn't something that happened back in, I've worked in OTPs during college from 2010 to 2014. I wouldn't get a call back from a residential, be like, we don't want your people here. So I've seen that change too.
What was the topic of your presentation?
Linkages to care. So basically setting people up for success after they've been incarcerated, but developing some kind of warm handoff upon release. So some of the things that we've implemented is peer supports, picking that individual up from the facility, taking them into the clinic, because that can be an anxiety-driven task. You get out of jail and then you're supposed to go to a clinic, and even walking into a clinic can be a lot, So those types of things, we have peer supports go in, special focus on pregnancy populations where do they need residential? Do they need to escape a troubled relationship? Do they need an OBGYN? Do they got that? Prenatal care, family classes, because one of the things I always find funny is that we put parents in parenting classes after the babies arrived, but what if we did it before? I think we don't have to have the fire start. So those types of things, and just do they need residential? Do they need IOP? Do they need a higher level of care than what we can't offer? So we have a lot of system partners in any kind of community that we work in.
Who funds these programs? Are they from the federal, state, or local level?
Combination. So we were lucky enough to get the Matt Padoa grant. So we kind of had 3 years to figure out if it made sense to do this strategy and those types of things. I've heard different ideas. It's definitely a combination for our staff and our company. So a lot of companies may put money into advertising or marketing. We can take a chunk out of that and hire actual people to do pro bono work inside jails. Grants definitely help because you cannot reimburse for services behind the walls. But there are little tricks of the trade, or, to support your community is advertising in itself and marketing in itself, because those agencies will then sing to the heavens for you, and they'll say, what a great system partner, and those types of things. And so some of those tricks can be brought on. Sustainable wise, I think as behavioral agency, especially residentials right now, they're struggling to keep their beds full and those types of things. But if you're working closely with a jail or closely with other system partners, a community in general, the referrals kind of come out of those relationships. So really being involved in the community provides your business to flourish.
Do you have anything you would like to add?
I don't have much except for one thing I think we as people who have already gone down this road and implemented MAT into corrections and those types of things, we take for granted is how close-knit and understanding the community is, and how difficult it can be to implement services, especially if you're trying to become an individually licensed OTP or to co-locate like Rhode Island's model, and those types of things, or even being the option 3, which is delivering community-based services from the community into the facility and those types of things, is that it really is a community that's willing to support you. So policies and procedures, workflows, all these other things. I remember back in the day, I did not have a buprenorphine policy and procedure, and it was going to take 3 months out of this project to probably see the legal department go down this road and these things. So I reached out to Dr. Clark of Rhode Island. She's like, here's my policy and procedure. And I was like, all right, thanks. You just saved us 3 months. And so I've been fortunate enough to be able to do that for other folks trying to become their own OTP and kind of share Maricopa County stuff, or share Montana stuff, or Alaska's, samples of MOUs or whatever. But there really is a community out there to save you a bunch of time. So it's not like death by delay or you lose that momentum. And so I think that's important to note for anybody that needs support, because there is a community out there to support you.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.